Yeah, thank you very much, Christoph, and thank you very much for the organizers, of course, to invite me here to talk about AF telecare and app-based management. I will also particularly focus on the Telecheck AF project, which we performed together with a lot of centers and a lot of people who are also here in the audience during COVID-19. So we performed recently a systematic review to look at the sensitivity specificity, so more or less on the accuracy of different devices which are currently used for the assessment, the detection, but also the diagnosis of atrial fibrillation. And you can see that actually most of those variables and also most of those apps are quite accurate. The thing is that different techniques are of course used to either detect or diagnose atrial fibrillation. And there's one very important point. So ECG is still required in the current guidelines to of course diagnose atrial fibrillation. So it's either a 12-lead ECG or when it comes to variables, it's a 30-second one-lead recording of atrial fibrillation, which is of course not provided, for example, by PPG recordings. So most of the apps which actually use photoplethysmography are not useful to diagnose atrial fibrillation, but they can be very, very useful to detect atrial fibrillation in patients who are already diagnosed with atrial fibrillation. There's also another difference between PPG and ECG, and this is we as cardiologists, nurses, and allied health are very used to look at ECG recordings, but we are not very used to look at PPG recordings. And this is why we put together also with a lot of centers from the Telecheck AF project, this PPG dictionary. So it's really a structured and stepwise practical guide how to evaluate, look at PPG recordings. And this is now also published at the European Heart Journal Digital Health in this month. So just look at this if you wanted to learn more about this. The best app cannot change the outcome of our patients. I think we have already talked about this. It's really about integration. It's about the interaction and also the facilitation of technology-human interaction. And what I exactly mean with this is indicated here in this figure. So the first blue part is mHealth operability, connectivity, and data storage. This is what the mHealth companies really invest a lot in at the moment, and this gets better and better and better. But the green part and the last part, this is really where we as cardiologists, nurses, allied health really play the most relevant role. We need to identify those data points which are actionable, which are meaningful, and we also need to understand how to integrate this. Because if we cannot integrate this in the pathways, interventions, treatment, monitoring, and prevention will not change. So this is really the point where we need to understand how to improve this. Telecheck AF, what is actually Telecheck AF? Telecheck did not invent the way how to perform teleconsultation during COVID. No, it's more actually a project where we tried to first describe, but then also make infrastructure and also ideas how to use those apps around teleconsultation available is in many centers as possible. Telecheck AF, the idea is to use a teleconsultation approach. This can be teleconsultation or also video conference, and to use an app or wearable device on demand for example, 7 days just before the teleconsultation to really get the information about the rhythm of the patient who you are consulting via teleconsultation, and then also trying to include this into a comprehensive AF management. And this is actually Telecheck AF. We described this in a manuscript initially, and then we on Zoom contacted a lot of different centers. Here, for example, is when we contacted Liverpool, we also contacted Antwerp, Cologne, Graz, a lot of Hanover, a lot of other centers here in this room. And we just told everybody, well, this is how it works in Maastricht. This is just a proposal. Here you have the infrastructure, just start to play and try to find the best way for your center how to use it. And this was then actually the last stage. So it's 41 centers, more than 230 caregivers, and more than 4,000 patients who have been actually managed in this approach around teleconsultation. We also have collected more than 68,000 PPG recordings, which of course also might provide some interesting information. What kind of patients did we actually manage? So this is not the result of all patients. This is just the result of 1,480 patients within Telecheck AF. Those patients are patients. So they are older patients. They are those patients who we see normally in the outpatient clinic, and they can use apps. I think this is what we really learned. The oldest patient in this data set is 92. This lady actually downloaded the app and was able to record for 7 days before teleconsultation, really with a PPG-based app, the recordings. Comorbidities, those are our patients. So they actually have the typical comorbidities which we actually expect, and measurements within this approach for 1 week before teleconsultation. So the idea was 3 recordings per day for 7 days, so 21 recordings, and the median number of measurements indeed was 21. So the adherence in most of those patients was very good. What do actually patients think about when we provide them an app? This is of course also very important. Agreeing is green, not agreeing is in red. And here you can see different questions. For example, I liked using this app FePCheck, which we used in Telecheck AF, so that my doctor has information on my heart rate and rhythm. And most of the patients agreed with this. I would like to use this app in the future. Also a lot of agreement. I found the daily notification to remind me to make registration useful. I found the use of this app easy, and I found the manual and installation of the FePCheck app easy, a lot of agreement. However, we also need to focus on this one. So even mHealth can have side effects and can even be harmful. And we need to identify those patients who can profit from this and who also might get better with mHealth. There might be also some who actually, where it exactly goes to the other direction. Emma already mentioned, and also Hein already mentioned, the treatment of atrial fibrillation is in this case not just B, but also A, B, C. And the more we go remote, the more we actually need to understand how we can actually remotely assess the ABC and manage the ABC. So for example, when it comes to anticoagulation, we need to think about how can we actually assess the CHEPS-VAS score remotely. And this is data again from Telecheck AF, 994 patients. And in this app, different questions related to the CHEPS-VAS score is actually done. And you can see then here in the middle, on the y-axis, the app-based CHEPS-VAS score, and on the x-axis, the electronic health record-based CHEPS-VAS score of those patients. You can see there's quite a good agreement. However, some of the patients overestimate or underestimate their risk assessed by the CHEPS-VAS score, dependent on the survey which is provided by this app. And does this have an implication? Where this is shown here, you can see on the left-hand side then the oral anticoagulation with indication based on the electronic health record, and on the right-hand side, those with no indication based on the electronic health record. And you can see that 6.1% of all of those patients where we would think based on the electronic health record that they need anticoagulation would be actually not treated, and 26% of those patients where we think do not have an indication for anticoagulation would be overtreated if we would just believe the app-based assessment of the CHEPS-VAS score. Whether this is acceptable or not, well, this is of course where we need to agree on, but I think it shows that our patients know a lot about their risk factors, and we might be able to use this also in the future. Simultaneous symptom and rhythm monitoring. This is also something what we learned can be very interesting. Here, 2 patients on the left-hand side, actually around cardioversion, where you can see the arrow, and then you have a short period of sinus rhythm, then early recurrence. On the right-hand side, you have a patient with, again, a shock, and then actually sinus rhythm afterwards continuously. And if you monitor symptoms and rhythms at the same time, then you might sometimes see this. So on the left-hand side, for example, you have improvement of symptoms around sinus rhythm. So this would be a good symptom rhythm correlation. On the right-hand side, no change in the symptoms based on the cardioversion and sinus rhythm, so a bad symptom rhythm correlation. And if we now think about no asymptomatic or symptomatic AF patients, which is now actually more or less this category which we are mainly focusing on, this might introduce a complete new dimension. So we have now a better or less good symptom rhythm correlation, and we can also start to think about symptom burden instead of just asymptomatic, symptomatic AF patients. When it now comes to comorbidities, well, there's a lot to do. And already, of course, in face-to-face setting, it's very tricky, and it will get much, much tricky when we go remote. I think there are some things like obesity, body mass index. Well, this can be assessed, of course, at home by the patient, and this can be also very accurate. But for example, if we think about diabetes, hyperlipidemia, sleep apnea, those are all things which are tricky to assess remotely if the patient is not in the hospital. those tools might actually play a role in the future. So if we think about our patients can use those devices, we know this from the vitamin K antagonist era, and there it worked very well. This point of care whole blood assessment, but not now just to assess the INR, but now to assess the creatinine, HbA1c cholesterol, to actually remotely get an idea about the risk factors of our patients. And then sleep apnea, well, that's my main hobby, of course, besides atrial fibrillation. And we in Maastricht do it in this way. Again, a remote assessment. We send this device to our patients. It's disposable. The patients actually use it at home. And then it links to a mobile phone. The information is sent to a cloud, and the patients are assessed remotely. Actually, and also CPAP can be introduced remotely. We put this together in a manuscript, which will be published in Europace very soon. Now, actually, of course, also again, back to integration. So we have already quite a lot of scenarios where remote monitoring might be interesting also, of course, to really manage our patients. And here you can see the guidelines to manage patients around cardioversion. And already there we have two different options at the moment, either shocking directly or actually waiting for 48 hours. This is the result of the race 7 Aquas trial. And the idea would be then, well, can we maybe even wait even longer to allow even more patients to convert spontaneously instead of just waiting for 48 hours? And there again, mHealth might play a role. This is currently investigated in Maastricht in the Observe AF trial. So our idea is to compare standard of care, which is even directly cardioversion or cardioversion within 48 hours, compared to watchful waiting for 4 weeks. And this waiting for 4 weeks is particularly a challenge because we need to see, is the patient too fast, too slow? So rate control is very important. And also, of course, if they convert spontaneously. And this is what we implemented in this trial. It's actually an alert-based mHealth infrastructure. The patient is provided with an app, and then daily measurements are sent through via cloud. We implemented alerts, bradycardia, tachycardia, and increases of symptoms and spontaneous conversion, which is then actually provided to the care team, and the care team can integrate this information in the management of the patients within those 4 weeks. And the primary endpoint is then actually more or less within this non-inferiority setting, sinus rhythm at 4 weeks. Secondary endpoints are also hospitalization and others. So ladies and gentlemen, I would like to summarize. There can be a role of digital AF management pathways. We need still to define them. We still need to see how it works best. Challenges for remote AF management is mainly the integration into the clinical pathways, facilitation of this technology-human interaction, which we as physicians, nurses, allied health need to take care for, identification of actionable data, then remote risk factors and CHETS-VASC assessment. This needs to be also improved. And finally, in the mHealth setting, the patient gets a very active role. The patient is now using the app instead that the patient actually comes to the outpatient clinic and an ECG is written. So from a very passive role, the patient suddenly becomes very, very active. And we need their education, engagement, that actually this complete setting can work. Thank you.